Hey, hello everyone, and welcome. My name is Sandra Alexander, and I am the project manager for Circular Clinical Care, which is a project by the Canadian Coalition for Green Healthcare being undertaken with the financial support of Environment and Climate Change Canada. And I would like to welcome you on behalf of the team to our third webinar for Plastics Reduction Week, focused on opportunities to reduce single-use plastics among healthcare textiles. We're very grateful to have such a diverse audience representing various hospital departments across various Canadian provinces and among various countries across the world. The diversity of the audience itself really highlights the interdisciplinary commitment to collaboratively reducing single-use plastic waste in healthcare, and we're grateful to spend this webinar hour with you. So healthcare textiles are vital for the delivery of care, but they often generate high amounts of waste. While our team does acknowledge that plastics play an important role in patient safety and infection control, we also do believe that there are various opportunities to promote a more circular economy and more resilient supply chains without compromising the quality of patient care. So during the webinar today, we will explore the exponential growth of single-use plastic waste generated by the healthcare sector, which led to the launch of the Circular Clinical Care Single-Use Plastics Reduction Project. And then we will also hear from Jerome, who is the executive at the Canadian Coalition for Green Healthcare's sister organization, SSE, which is based in Quebec. Jerome is also the chair of the coalition's board. And then we will hear from anesthesiologist Dr. Dernis, who is a part of a hospital team in Quebec that collaborated with a Canadian manufacturer, Fret Solutions, to implement a reusable masks initiative. And so we are very excited to dive into these solutions with you, and we encourage your questions and ideas throughout the session using the chat and the Q&A function. So with that, let's get started.
Hello, everyone. A warm and cordial welcome to this webinar on opportunities for reduction and circular reuse under the category of textiles in healthcare. My name is Tipu, and I am a research associate at the Coalition. I have an academic background in interdisciplinary science, clinical research, and global health. And as part of my work, I primarily support with the development of business cases and case studies for the Circular Clinical Care Project. And certainly many of these deliverables involve textiles, which I am so excited to share about today. We have knitted this webinar together with a 5-layered agenda. We will begin by establishing the burden of plastics on the healthcare system, as well as highlighting some plastics that are found in common textiles. Then I will pass it to our project manager to explore the human and planetary health implications of these plastics. We will then come back and unravel 3 opportunities for reducing single-use textiles in hospital settings, conjoined with subsequent opportunities for reuse and reusable alternatives right after. At that time, we will hear from the Coalition's board chair about partnerships, and they will introduce our special guest, Dr. Lindy Adernis, to discuss their experiences during the pilot of a reusable surgical mask that was made in Canada. If you have questions or comments as we make our way through, please feel free to add these in the Q&A session. Plastics are synthetic materials made from polymers that can be molded into solid forms. In healthcare, common plastics are found in medical products and are used along processes and procedures. Common plastics such as polyethylene and polypropylene are listed on this slide and are involved in textiles. While used widely, healthcare plastics are still contributors to the global implications of plastic waste. Between 1950 and 2017, about 9.2 billion tons of plastic accumulated globally. That number continues to grow and is only exacerbated by mass production of items across all industries. The healthcare sector is no exception. In fact, a report found that less than 5% of healthcare plastics are recycled across North America and Europe. We are on track to exceed 1 billion tons of accumulated plastics globally in the next 25 years. Recently, a report was published by Eunomia and Systemic or System IQ entitled A Prescription for Change, which investigated the magnitude of plastic waste in healthcare across Europe and North America. Now, this report had a hyper focus on advancing the circular economy by providing a roadmap of evidence-based strategies for change. Our project manager, Sandra, and project advisor, Linda, are listed as contributors on this work, and some key takeaways include that without intervention, hospitals across the US and Canada could reach 3.6 million tons of carbon dioxide equivalents per year by 2040. Now, this is carbon data, and there's also a model that scales these numbers by our units of scope, which are plastic and plastic weight. Taken together, across European and North American continents, single-use plastic items in healthcare were responsible for 9.3 million tons of carbon dioxide equivalent emissions in 2023 alone. Now, in seeking alternatives, many sources use the word circular, and for our purpose, circularity doesn't necessarily mean recycling. Like for textiles, we do not primarily seek to recycle masks, gowns, flannels, flat sheets, drapes, or table covers. It means reuse. And circularity through reuse is big savings. These plastics costed the system an approximate overall $56 billion in 2023 alone. The report suggests that common barriers to implementing reusables in practice are cost competitiveness, firstly, where single-use disposable textiles, such as gowns, have lower upfront costs than the reusable counterparts. Just the time that it takes to reach cost neutrality, even if it's short, can be a barrier. Um, Also, regulatory exemptions, which is a greater barrier in Canada when compared to the European Union, in that our regulations don't necessarily motivate the sector to undertake reusables and the production of reusables. We also have strict and conservational requirements surrounding infection prevention. Cascades had a whole webinar on IPAC considerations and sustainability. And this is not a force that we go against. It's an important pillar that we align with. What makes it difficult sometimes is the last point, in that it's a fragmented landscape where sustainable practices are not standardized across healthcare facilities. And there are different dynamics that certainly need to be considered across different facilities. We integrate these factors to help us work with these barriers within our business cases, which is important because if we don't catalyze change, projections show that the weight of plastic waste, greenhouse gas emissions, and costs will all continue to increase by approximately at least a third over the next 15 years. Circular practices over the next 15 years can reduce plastic use by up to 53% and can reduce greenhouse gas emissions by up to 55%. Now, this Eunomia and System IQ report is not holistically representative of all textiles. For instance, in any of the categories on the screen wouldn't include drapes. But even so, 11% of the system level plastics burden has to do with PPE, which involves textiles. As a parallel to what we've discussed within the Eunomia and System IQ report, a Lancet publication suggests that globally, 15 billion face masks are thrown away each year. The anthropogenic human-made problem becomes exacerbated when circularity doesn't meet its fullest potential. When recycling, matter matters because less than 10% of this material is recycled. The big fish is reuse. And here are some examples from a 2023 research paper by Morris and Murray. The figure on the right is from the report and shows single-use textile waste. This is the type of PPE waste that the System IQ and Eunomia report is inclusive of. The figure on the left is also from the paper and shows the components of a surgical mask and its non-woven plastic polypropylene fibers. The paper does discuss the viability of some reusables, and this academic research is complemented by examples of contemporary applications of reusable textiles, some in Canada and many in Europe. Some common textiles in hospitals, along with their plastic composition, include the ones on this slide, which at least lists some, such as polypropylene, polyethylene, and polyester. Each of these textiles have reduction potentials to a certain degree, which may vary per facility, and all of these categories have reuse potential as well. Plastics not only harm the environment, as we've seen, but when interacted with so closely, can also have human health implications. And at this time, I will pass the floor to Sandra to discuss some of these implications.
Thank you, Tipu. It is quite notable how plastics can directly and indirectly impact human health and planetary health. So, plastics impact human health in various ways due to the presence of toxic additives and the release of microplastics, and by extension, nanoplastics. So, a term to be familiar with is chemical leaching, which, when we're talking about plastics, refers to the process where chemicals added to plastic during manufacturing can break free and migrate into their surrounding environment, which includes water, food, and soil. A specific example of an additive is BPA. BPA is a key component in the production of polycarbonate, which is a type of plastic that is known for its strength, its clarity, and resistance to heat and impact. And so this makes it very suitable for a wide range of applications, including things like bottles, food storage containers, and eyeglasses lens. The problem is that BPA can leach into the environment and into human tissues. And in the body, it can act as an endocrine disruptor, which means that it interferes with the normal functioning of hormones by mimicking or blocking the natural hormones. This can lead to significant endocrine system disruption, affecting several key processes, which results with impacts on reproductive health, thyroid function, and development processes, which could lead to risks for diseases. Commonly referred to, common diseases would be type 2 diabetes or cancer. So at a very high level overview, plastics represent a multifaceted threat to human health, both through direct toxins and also the long-term biological impact of having microplastic accumulation into the body system. Specifically, there are some chemicals of concern that stem from single-use plastics, and these interlinkages are also present in their health implications. When we zoom in into the chemicals of concern, there are over 13,000 monomers, and more than 3,000 of them are of concern to human health, according to the United Nations Environmental Program. Another example of a concern is PFAS, which is an umbrella term that covers a group of human-made chemicals that are primarily used because of their water and oil repellent properties, and they are commonly known as the forever chemicals. PFAS are very commonly found specifically in PPE, like surgical gloves and gowns, in the manufacturing of tubes or filters. Even the hospital walls may have a coating on top of the paint that has PFAS. And so PFAS has been linked to numerous illnesses and chronic diseases, which could lead individuals to the hospital. And as plastics degrade, they break down into microplastics, which are particles that are smaller than 5 millimeters. They are easily ingested through, again, food, water, or just from the air, the inhalation. Microplastics have been found to accumulate in our tissues, including the liver, lungs, and kidneys. And so research has shown using electron microscopy and X-ray fluorescence, they've shown that microplastics can use or cause cellular inflammation, triggering a cascade of immune responses that may further lead to chronic diseases, such as autoimmune disorders or lung diseases, or potentially developing neurodegenerative conditions. And so these smaller plastics measure between 1 to 10 micrometers, or about 1/7 of the thickness of human hair. And they pose more of a health threat, these nanoplastics, because they can now more easily start to disrupt our cells' functions by actually crossing through blood-brain barriers and also moving among tissues. And so findings suggest that the impact of this inflammation can actually start to be a lot worse than we realize. And so looking further into the research, studies have shown that we inhale up to 68,000 plastic particles per day, which equates to the average person having 7 grams of microplastics into their body. So when we multiply 7 grams by Canada's population, which was an estimated 41.4 million people on October 1st, 2024, the math shows that the human bodies of the people living in Canada are essentially vessels that are carrying a combined weight of 290,000 kilograms of microplastics. And so really all of this is to say why we need to take action and take it urgently. And so this leads us to the launch of the Circular Clinical Care Project, which is a 3-year project being undertaken with the financial support of Environment and Climate Change Canada. And so if I had to summarize our project in a few words, I would say that we are an interdisciplinary team committed to sustainably reducing single-use plastic waste in healthcare across 4 areas that we have identified as hotspots for plastic waste. And we have 3 partners. Our pilot partner is Hamilton Health Sciences, which is a network of hospitals in Hamilton, Ontario, Canada. And it is the only hospital system in Ontario that cares for all ages, from pre-birth to the end of life. And they are a world-renowned hospital for healthcare research, which is correlated to their collaborative relationship with McMaster University, especially with the School of Medicine, which is a full project-long partner of the Circular Clinical Care Project. And within the School of Medicine, we have partnered with McMaster University's Postgraduate Medical Education, which is a program that our Executive Director, Dr. Sargent, leads the sustainability stream. And we collaborate with medical residents to implement quality improvement projects. So just for clarity, residents have their MD, they are doctors, but they are now training into their specialty. And so we collaborate with them to implement projects across our pilot site. And we also have a project-long relationship with Peach Health Ontario, which is a collaborative group based in McMaster University, but their work does span across Ontario. And so in terms of our project, they support our knowledge translation work. And at this point, we are 12 months into the project, and we are starting to transition to a national campaign. And textiles is one of the hotspot areas that we focus upon to identify ways that we can safely reduce waste and promote more wear.
Thank you.
So I'll pass
And
it
now
over to you, Tito.
let's delve into some opportunities for reducing textiles within healthcare. In our repository, which we discussed on Monday, there are 3 superstar reduction initiatives that have existing metrics to go along with them, and we will go over all 3 pathways. If you are interested in pursuing one of these or would like to learn more within the context of your facility, please connect with us, starting with linen cart reduction. This is a practical example of successful reduction in textile use from a frontline team at South Lake Hospital. In an outpatient cardiac diagnostic department, a team member noticed that their linen use was much higher than expected, not because it was needed for patient care, but just because it was available. Sorry. And in addition, feedback from their full service vendor suggested that their particular soiled linen that was being brought back to be washed were 8 to 10% lighter than the linen from other sites. And so with the support from leadership and peers, they introduced a few simple but strategic changes which really worked. They set up top-up quotas, ordering linen only when needed and not automatically. They collected feedback from frontline housekeepers to understand real usage, and they held conversation circles, casual team huddles to explain that their department had exceeded its use quotas and to answer any questions. Now, initially, staff were hesitant to see a sparse linen cart, but once they understood that more linen could always be requested if needed, it shifted from the mindset of providing linen just in case to providing linen um, at a frequency that was just right. And over 6 months, the department saw an incredible reduction of 49% in linen use without compromising patient care. Our next initiative is an example that we are assessing data for from our current pilot site, and it's also one with global interest. This is an example of reducing textile-related waste in clinical care from a published case in the gray literature focused on cataract surgery. In this case, a practice assessed its use of full surgical drapes and identified that large drapes were being used to cover areas that weren't involved in the surgical field. And by switching to half drapes, which still met clinical and infection control requirements, the practice reported a projected 50% reduction in plastic containing textile waste, and along with the associated cost savings as well. This was described in an article published by Helio Ophthalmology, which outlined a number of strategies under review to reduce surgical waste. And this final pathway is one that gets me excited. It's one that improves patient outcomes while also reducing textile waste. It's urinary incontinence pad reduction. On this slide are three global case studies where hospitals implemented incontinence pad reduction strategies. All of these hospitals essentially increased toileting of patients, reduced pad use, and genuinely improved patient outcomes by providing holistic care. First, at Northampton General Hospital in the United Kingdom, the hospital completely eliminated urosepsis-related bloodstream infections caused by catheters. They reduced the use of large continence products and employed a continence specialist nurse. They also removed large pads from their procurement system entirely, helping staff adopt better incontinence management practices. At the Great Western Hospital in Swindon, the team noticed an overuse of incontinence pads, whereby sometimes multiple pads were being used at once, even for continence or continent patients. Their intervention focused on staff training, and as a result, they saw a reduction in bed sores, improved patient dignity and mobility, and a 27% decrease in incontinence pad spending over a 1 year period. And lastly, our largest box on this slide, because the one that I have the most information for, so it's almost symbolic, at Clontarf Hospital in Ireland, the team implemented a comprehensive continence improvement program involving screening, staff training, bladder training, physiotherapy, and dietary changes. Amazingly, 47% of patients that were admitted with incontinence regained their bladder control. Regain their bladder control by discharge. And the hospital saved over 17,000 Canadian dollars in direct product costs. And I recognize that this doesn't seem like a lot in procurement savings, but these cost savings do not account for procedure level savings from treating infections or from early discharge. They also saw reductions in incontinence related dermatitis and pressure ulcers. And these examples demonstrate that thoughtful process changes can lead to safer, more dignified patient care while also reducing environmental impact and costs. Now that we've charted some opportunities for reduction, let's revisit a part of the repository. This slide just shows the scale of opportunity that is out there. Is over 70 ways that we can reduce single-use plastics just in textiles alone, from reusable surgical masks and gowns to linen bags and drapes and even shoe covers. There's a wide range of areas that reusables exist as options and are even being piloted. And part of what makes that possible are Canadian vendors supporting supply chain resiliency. On this slide, I've listed a few examples of Canadian vendors currently offering reusable textile products that we have come across. These include suppliers for drapes and continence pads, gowns, sterilization pouches, masks, and more. And this list is by no means exhaustive or endorsed. It's just a starting point. And if you know any Canadian vendors, or if you are a Canadian vendor and you're not on this list, please, please, please feel free to add about that in the chat or to get in touch with us, I would be delighted to add you to our list. The more Canadian vendors we have, stronger our supply chain resilience rationale. The benefits of reusables are truly, truly widespread. First, reusables offer environmental benefits. Life cycle assessments show that they use fewer resources and generate fewer greenhouse gas emissions compared to these single-use items, especially when amortized over their reuse potential. From a financial perspective, reusables are often more cost-effective in the long term, and there are also social benefits. Reusables need to be cleaned and sterilized, which supports local jobs, either in-house, in-hospital laundry, or even through external full-service Canadian vendors. Another key point is supply chain security. When there's a disruption, reusables can be reprocessed with little reliance on procurement. These advantages, combined with global data on plastic waste and health, system audits are what led the coalition to advance this work. And now I will pass the floor to the coalition's board chair, who will also introduce our guest, Dr. Lindia Dernis.
Thanks a lot, Tipu. So, as mentioned earlier, my name is Jérôme Ribes. I'm the Executive Director of Synergie Santé Environnement, so SSE, to make it easier. So we are not-for-profit based in Quebec. We've been active since 2006, working with healthcare organizations across the province of Quebec on sustainable healthcare, so waste management, EPP, governance, carbon audits, climate change mitigation or climate change adaptation. So we've been, as Sandra was mentioning, we are sister organization, the coalition and SSE. So we've been trying to work together since a long time. So the idea is to break up silos. So we know that there are lots of silos in healthcare organizations. So in each of our provinces, but it's far worse when you're thinking about trying to know what's happening in Quebec when you are in BC and vice versa. So that's the kind of stuff we are trying to work on with the coalition. And just a quick information, we've been working at SSC at organizing an annual conference on sustainable healthcare, and next year, so in April 30, 2026, will be the first time we will have a national conference on sustainable healthcare. It will be co-organized with the Canadian Coalition and Accreditation Canada. So that's the kind of job we are trying to do together. So when we are talking about a project like the one Lindia will be talking about in a few minutes, of course, it's really important for the coalition, for example, to have access to Quebec. So we are probably, better placed than the coalition. We've got the links with people from Quebec hospitals. So basically, that's what we've been doing, easing the talk with Lindia and her colleagues, making surveys, discussing with people, trying to organize meetings when possible. And the idea was to interview people and to try to gather some better information for Tipu and Sandra to do their work and to analyze the project. And of course, we've been working a lot on translation. ChatGPT and Google Translate are not that good. So we are trying to work also on this. And I'd like perhaps just to finish to say that collaboration is really an essential part of the job that we are doing. Of course, I know really well Lindia, so it was quite easy to work with her and to have access to lots of people working in the hospital. She's been implementing the project. And what we are trying to do, I think, the coalition and SSC and other organizations across the world is try to help not reinvent the wheel. So that's basically the idea, trying to share the best practices and to share also innovative solutions as the one that Lindia will be showcasing just now, in fact. So Lindia, I'm just giving you the lead to make your presentation, and I will leave you just present yourself the way you want to present yourself.
Thank you, Jérôme. Do you see my slide? Yes, perfect. So I'm an anesthesiologist. I work at St. Mary's Hospital in Montreal, and I'm just very aware of the waste we create. And I've been working for a few years now on trying to reduce and recycle when it's possible, whatever we do. So that's it. I'm gonna discuss about that crazy project that we've started. Whew, now 3 years ago. We started working on this. It's have washable mask in the operating room. Of course, before the pilot project, our hospital was relied like every other hospital on exclusively on disposable masks, most of them coming from Asia. And we there we go. And then we've started, pre-COVID, we've started a recycling program in our operating room. And after COVID, early 2021, we've decided to restart that recycling project, which was going quite well. And we've decided in 2022 to do a waste audit to kind of evaluate where we could make some improvement and to know also what kind of material we had. And we got actually very, very interesting numbers. We could see that we recycled 16% of every waste we generated in our OR. And we also evaluated biomedical waste and municipal solid waste. The black part is the municipal solid waste. And we've opened our black garbages and we wanted to know what kind of material were we throwing. And we kind of set aside what is written linens. So it was surgical drapes and it was also surgical gowns. And you can see that it's almost the same amount of recycling. It's 15%. And the biomedical waste is already too big. That's something we worked on too. Biomedical waste should not be the same amount of regular waste. So we probably have also a lot of linens and a lot of, like sterile gowns and drapes in the biomedical waste. So we've realized that all this, well, plastic, it's made of plastic. So all those plastics that we knew would be possibly swapped to washable were like a huge part of our waste, more than 15%. So we've started to think about how could we manage to change this. The only thing is that to go to washable or reusable surgical gowns or surgical drapes is a bit complicated in a way that you really have to have, like, you can't do it in your own laundry place. It has to be in a special place. It has to be with a special table, whether it's a folding table. It's also like there's a light in that table so they can see if there's a hole in it. They can see if there's like debris in it. So it really has to, the investment to start something like this was huge. And you have to understand the project that we do at St. Mary's Hospital are just projects done by people who are just motivated by it. We have no budget. We have no project manager attached to us. It's just like goodwill. So it needed to be like easy. We can't just like change all of it. And we've decided to try to more so focus on something that was smaller, but that could be seen and that could change a bit the ideas of people on it. And then it would bring us to a bigger change. So we've decided to see what we could do with just washable masks. I came across a company that was actually also from Quebec that made surgical masks and tried to look into what was doable. So first, because like I told you, we have zero resource. When we try to do like a big project, we don't want to waste our time. It's already going to be extremely time consuming. So we want to make sure that, first of all, the clinical requirements to have like something new in the operating room were met. We don't want to add any risk to the patient. We don't want to have any, bad publicity or any, like anything that could be, a bad complication attached to a sustainability project. It was very important. And of course, we don't want to waste our time on something that is not beneficial for ecology, for sustainability upfront. So we had to look into this before really starting the project. So, well, luckily, all the masks we were working on, and we've discussed with the producer, which is Fred Solution, they had already all the agreements. It was Santé Canada approved. It was approved whether it was the filtration, whether it was the way to wash it, whether it was I forgot the name, but they've tested, how it does the wash take all particles or microorganism off that mask and everything. And the filtration after 100 wash, everything was done already, and everything was perfectly adapted to an operating room setting. It's a very strict environment, and you have to go by it. You can't just like start something new and say, well, we'll do the studies later. You don't want to risk anything for the patients. So this is how it went for that first part. And then we wanted to know, is it really interesting on an ecological point of view? Well, the life cycle assessment was already made, and definitely the emissions were reduced by 80% when you take, like the full life cycle assessment of the whole use of the mask. But also the water waste and the plastic that was used. I mean, like you reduce so much. And there were other studies that were made about those masks that came after the project was started. They reduce microplastic also, and tons of different articles that came out afterwards, but there are still to the benefit of those masks. So once we've decided that the project was clearly doable, economically, ecologically interesting, and no risk added for the patient. So who's gonna be on the team? So it was easy. The OR, that's kind of me. I'm the anesthesiologist. I talked to my team, and you agree? We agree. Okay, let's go. We're happy. And then two big stakeholders were laundry. They will have to wash the masks, and prevention, infection control prevention. So laundry took 2 minutes. We're lucky enough to have someone extremely motivated, Adam Gelinas Prou, for those who know him. And he said, no problem, no problem. We can do it. I'm very excited about that project. We can do it. So that was easy. The other part that took probably almost 2 years to get through was our Department of Infection Prevention and Control. It's complicated for them. They had tons of questions. We provided all the literature, all the legislation, but they have to go again through all of this. And of course, they have to go through this. Well, it's not in their job description. I'm asking them to do extra jobs. So it's kind of like not easy. And the fact that when you're the first, people are always a bit reticent. They're kind of, do I want to be the first to do something? I'm not sure. It's just brand new, even though I have all the data. No one wanted to do it before. Why? So it was really not easy. So they ask us to write a full protocol, which is fine. Like the wash protocol, it has to be, like washed separately. It has to be washed with certain type of soap, and then heated to dry at a certain, like temperature. So yes, but we also had to write a wear protocol. so we've asked, okay, can we have the wear protocol for the single-use mask? We're just like, copy paste, and but then we're not. And we're like, yeah, no, everyone knows how to wear a mask, but it's different. Like, how is it different? Like, what will you do if you touch your mask with soiled hands? I'm like, the same thing that I would do if I had a single-use mask. It's the same, but very complicated to get things. So we had to write that protocol. And yes, the traceability of the number of wash was extremely important also for the IPAC team, because the study were made for 100 wash, which means that after 100 wash, the filtration of the mask is maintained, but they don't know about 102 wash, for example. So the mask has to be, when you get a mask, you have to know how many times it's been worn and washed. So this can be kind of complicated, and I'll show you a bit later how we've done it, because you can put, like a RFID chip in each mask, which is extremely costly. You can you can have also a little QR code, or, like a whatever a code on the mask, but then you would have someone to, like scan the code for each mask, which is the laundry. It took 2 minutes to say yes, but probably it would have taken longer if it takes a lot more work to the people working in the laundry. So whatever, it took us 2 years to get all together on the same page with the agreement of, I don't know how many committees in our hospital, like probably 9, and we end up having an agreement and a protocol, and everything was agreed. I'm going to show you how it works on a practical point of view. And we've started and we've monitored breathability and comfort and like the cleaning cycle, and we've gathered feedback from users. We started mostly with anesthesiologists, and the first masks were actually prototypes. So we were able to change a bit, like the the stickers and things that were, like bothersome. And you'll see on the right is, there you go. So this is how it works. You're supposed to wash your hands before taking a mask, a washable mask. Of course, the other ones, it's different. I don't know why, and you just put it, and that's it. You have your mask. And you can see on the picture to the right, you have that little blue part, which is because we didn't have any budget. The RFID chip would be fantastic, but we don't have that budget. The way we've washed and we had traceability of the mask, of the number of wash, is that we had color batches. So you see on the mask on the side, you had that blue little part. Well, where you take your mask has also a blue little part. And when you're done with your day, when you're done with your mask, the next at the end of your day, or when it's soiled or whatever, you have where you put the masks in, and you see that blue part where, so you know that you have like the blue batch, and the blue batch is scanned once, and you know that that batch has been washed that number of times, which is much easier for laundry, and it doesn't take like so much time. So this is how we've done it. This is how it works at our place. We've learned a few lessons. First, yesterday evening, we were awarded for our work about that project. But we did learn things from that project because it was not easy, and we could have worked better if we had more communication with different teams, the nursing teams and probably the IPAC team, and to have also management support. Without management support, whether it's to have, like a project manager or higher in the administration, probably that we would have more buy-in, for example, from the nurses. And yeah, I would say that's it. And a lot of people think that, we have to do like a lot of studies and things like this. I think we're beyond this. Like, the technology is here, the technology exists, and we do have already all the accreditation and everything is already there. What's difficult is on the ground to get the teams to change. So, but it's doable, and we've done it, and we're very happy, and we've opened a door for other teams to do the same. And that's it.
Thank you, Dr. Dernis, for sharing about the project. And again, congratulations on the award. It's such an amazing achievement. And we're very thankful that we get to collaborate with you and the team and Jerome at SSE. And yes, so I don't see any questions in the Q&A, but we are welcoming any questions that you may have for our team. There are two comments in the chat that I can see. So for you, Tipu, London Hospital Linen Services is one for Southwest Ontario that is not on the list as a Canadian vendor. So we will include them. There is a comment, and I believe this will be for you, Dr. Dernis. There is strong messaging in local health board HNS teams that reusable face masks are not as reliable as disposable ones. It would be good to see some evidence that I can provide against that.
So it would depend on the mask you're using, of course. I know there's a lot of, like reusable masks that came out during COVID or right after COVID. So you need to have the data that have been, like proven. The masks that we use have shown that they are reliable. Even after 100 wash, they are actually better filtrating than single-use masks. There are a lot of things that are not known about our single-use masks. First is that some of them not only have microplastics, but part of the filtration has also very thin layers of PFAS. So as a healthcare worker, you're breathing micro PFAS the whole day you're working. So this is really something that we will have to address at one point. The healthcare workers' health. That's the first thing. The second thing is that we don't understand how those masks that we that we use, how they work. Most, if not all, of the single-use masks, the filtration they're providing is not only through the fabric, it's also because they're electronegatively charged, and the microparticles of whatever flies that you don't want to, that you want to be filtrated are just like kind of repelled by that electrostatic charge that is in the mask. This is why some masks are considered not working anymore after 4 hours of use. And this is why they tell you change your mask after 4 hours or after 2 hours, depending on the masks. Those washable masks are not charged whatsoever. It's the filtration is going to be the same throughout the whole day. So if you have, like some people, like anesthesiologists sometimes, that don't change their masks throughout the whole day, for example, whether it's a single use or a washable one, well, you'll have a better filtration at the end of your day with a washable mask. So there's a lot of things we have to relearn because we're just doing it, like there's no protocol for those masks because we know, or maybe we think we know. There's no, gel, to wash your hands. No one washes its hands before putting the single-use mask. But for the other one, hey, we were forced to do it. So, I mean, like we have to face, sometimes it's just logic. And we've just, we think we know, but we don't know. And we have to relook into it to quite understand.
Thank you. And Tipu also did reply to that comment, just mentioning that we are collaborating, all three of our teams, on a business case for reusable masks. And so if you get in contact with us, which Tipu has included his email, we would be happy to meet with you and kind of explore that in greater depth. There is a comment by Michelle, who is actually the founder of Red Solutions, who just put the term bioburden, which was in reference to Dr. Dernis's presentation. And so if anyone is wondering, bioburden, it refers to microorganisms present before sterilization. And so that's why the laundry process is so important. There is a question in the Q&A, Dr. Dernis, thanking you for such an impactful project. And they agree that sometimes people are hesitant when implementing something for the first time. Do you have any recommendations on what you did to increase buy-in and or excitement?
Well, it's not easy, and I think you have to know your team. I don't think you can have just like, someone telling you, now this is what's going to happen. It's not going to work. I think you have to know your team. You have to show, you have to be an example, but you have to bring other people and you have to make them try. And you have, sometimes you have to be a bit annoying and you have to, just try it. And then they say, oh, well, it feels comfortable and it's fine. And you'll get more and more buy-in. I got buy-in in my team of anesthesiologists, for example, but I didn't got that much buy-in, for example, with the nurses. But I didn't get any official support from, the nurses direction, and high manager. So I guess that it would be for them, it would be like a bit more complicated to try to have the buy-in, whereas, they're not pushed to do it and they don't need to look good to their boss with trying it. So you have to know your team. You also need to have, like kind of help from the other departments and the other specialty, which is where we probably could have worked a bit differently on our project. But and not pushing it on anyone who does not want to try it. Like to have the thing on a voluntary basis usually makes people more curious and more inclined to try than someone who is forced to do it.
I agree. Having community-based principles definitely supports buy-in. There's another question that said, or asked, how was the cost comparison of switching to reusable masks versus single use, not only in terms of direct costs, but indirect costs associated with washes, electrical consumption, etc.?
So I don't have our cost analysis because first of all, we were lucky. It was the prototype. So we were able to change masks throughout to, like regularly we would, do a kind of a debrief with the company, with Fred Solution. And we would kind of change slightly, like the attachment. We tried like behind, we tried with the loose, we tried like different things. So we didn't go to 100 wash to really make it, to make the cost analysis, we would have to go to the 100 wash. The other thing is that it's going to be different. We were like, for now, we were a very small team using it, at St. Mary's Hospital. But the price will go decreasingly. And then when you look at the amount of wash, for now, us is like, it's ridiculous. It's very small. So it doesn't take like really like a lot of, like time and the cost would be just like to buy the masks and it was dealt with laundry with something they had in their budget. They were able to do it, but it stays for now like as a pilot project with only people that are interested in working in it, and it doesn't cost us much. But I'm not sure we've saved either. It would have to be scaled at a larger level to be able to do something like this.
Yes, and going back to our business case, that is something that we explore as well. Again, using information given by the team that implemented it. So we would be happy to, for anyone who's interested, share that And also just being mindful that many who are working in hospital are also bound by contracts. And so we do encourage you to explore reusable textiles that are available through your vendor that comply with contract agreements. So that is change that could be more immediate, and explore other options of vendors when maybe the time is better for your organization. There is a question that said, is there a place where we could get more information, or can we schedule a call to learn more from you? Tipu and I would be happy to connect, and I'm sure Dr. Dernis, Jerome would be happy. And Michelle from Fret Solutions has also included her information in the chat. So we're all very happy to share the data that we have, our knowledge, and would be more than happy to meet with anyone who's interested. And there is a question that said, Dr. Dernis, can you share the WASH protocol?
I guess I can. I don't have it with me, but otherwise, the ideal way of having the protocol is to have the one from the company, which is, which is what we use, because we really, like, our IPAC department wanted, like, if it was proven to work and to be, properly washed with this, it's our laundry who has to adapt to what the company provides. So that's it. So in our case, we took what Fret Solutions asked us, how they asked us to wash the masks, and we just applied it.
Amazing. And all of these processes are validated by regulatory bodies. And yes, I think those are all of the questions. There is actually one that I just saw. Is there any work with things outside of masks? Yeah.
So outside of masks, I mean, the hats, for example, it's going to be different. I mean, you can use hats from probably anywhere, as long as they don't, send particles out, they would be accepted. So it doesn't really have, and they don't have to be washed in a special way. You're not breathing through your hat. So it should be like much, much easier. For aprons, I don't know, but there are a lot of, opportunities to find, surgical gowns, surgical drapes. I know Fret Solutions does some, but there are also other companies. The only thing is that you have to make sure some of them are made with Gore-Tex, which have PFAS, which have endocrine disruptors. So if you want to go back to reusable, try to go back to reusable in the first place with something that has no endocrine disruptors that will end up in our, water streams, or no PFAS, and that's it. If you want to go back to like something better for environment, just work it up like in depth.
Yes, I think that is a great way to end it off. We are at the hour, so I will put in the chat just one more time. If you'd like to join the rest of the events of this week, we would love to see you at 3 p.m. Eastern Time today. We will have a roundtable for discussions. If you'd like to drop by, the registration is through that link. So again, I'm happy to stay for an extra few minutes if anyone is typing any further questions. Otherwise, we thank you for joining us, and